welcome everyone. Thank you for joining us today. We have a very interesting topic today, the rare aplastic anemia combination with the hemolytic PNH disease. I think this is one of the entity that is usually misdiagnosed and has a lot of difficulties, is challenging disorders to treat both condition. And so I felt if we will invite the expert of bone marrow failure, then we will be able to find our way how to deal with this two very rare severe condition. And so my privilege to host Dr. Jaroslaw Maciejewski today. He is the chair of the Department of Translational Hematology and Oncology. So he did his MD and PhD program from Humboldt University, Berlin, Germany, and then his internal medicine residency in University of Nevada, and hematology fellowship at NIH, and worked with Neil Young. He's an attending hematologist specializing in bone marrow failure syndromes, inherited and acquired cytopenias, and MDS. He sees patients all over the world, and his research interests have evolved from molecular and immune mechanism of bone marrow failure syndromes, including MDS, leukemia genetics, and targeted drug discovery for these conditions. His laboratory has made several important contributions to understand these rare disorders, especially aplastic, PNH, and LGL. He has been mentoring several trainees all over the world over the last 25 years. Without further ado, we will go ahead and get started with the first case. So this is a 23-year-old Caucasian woman, female, came in with a few weeks of dark urine and difficulty swallowing. Further evaluation revealed her hemoglobin of 9 grams with ANC of 1500 and platelet count of 50, with the indirect bilirubinemia of 4 milligrams, with the LDH of 540 and retic count of 6% and low haptoglobin. And then because of this profound hemolysis picture, the PNH flow showed 65% granulocyte clone with a 20% RBC clone. And so the diagnosis of PNH was established, and she was monitored for 2 years without any treatment. And throughout this time, she experienced 4 frank hemolytic crises, mainly triggered by infections. When she presented to our clinic, we repeated her bone marrow. The bone marrow showed normal cellular with no dysplasia. FISH and cytogenetics were unremarkable. PNH flow showed 20% granulocyte clone with a 14% red blood cell clone. Basically, her clone size regressed significantly in couple years. And so her blood work showed hemoglobin of 13 with platelet 180, ANC 4,500, retic count 1%, LDH 250, and haptoglobin less than 8 with a insignificant bilirubin of 1. So basically, her disease kind of regressed, the aplastic along with the PNH. And so we have some questions to Dr. Maciejewski today. Can you please elaborate on how aplastic and PNH disease are diagnosed, including the key aspects of their diagnostic workup and at the hematopoiesis level, if there any intersection in between these two disorders? And can you go over the PNH disease classification? And what is your approach for newly diagnosed classical PNH disease with or without aplastic disease? And when do you start the complement inhibitor therapy for PNH patients? What's your threshold clone size or hemolytic markers? Which complement inhibitor do you prefer? Especially, we have more approved medication now. So it will be important to talk about that. And then how do you explain this clonal regression? I mean, is this something that we usually see, this PNH clone to regress and disappear?
Yeah. Well, in any event, PNH is usually a coincidental finding based on some triggers, namely some clues that symptomatology afford us. Particularly, patient might present obviously with anemia, and one can quickly established that this is hemolytic anemia. However, the Coombs test is negative, and which narrows the differential diagnosis of this type of hemolysis. It's intravascular hemolysis predominantly. Some patients present with iron deficiency due to iron loss via urine through hemosiderosis of so hemosiderin can be found on urine tests. It's not often conducted. LDH obviously elevated, haptoglobin might be low. However, some patients present without major hemolytic component with unusual thrombotic complications. The diagnosis is somehow easier in those who have extensive history of prior aplastic anemia, which reveals clue as to this clonal complication of aplastic anemia, in which case the pancytopenia can predominate the picture, and at that point the diagnosis is established using a flow cytometry. Some centers now these days perform also next generation sequencing, and many of the panels used to diagnose myeloid disorders contain sequence also the panel PGA gene. The genetic diagnosis by establishing the mutation, the presence of a mutation in PGA gene, is somehow less sensitive because it's performed usually on total blood DNA, in which case most of the lymphocytes are probably negative, and so they decrease the sensitivity of the testing as compared to the flow cytometry. Once the diagnosis is established, workup is necessary. Usually we like to know whether this is type 2 or type 3 PNH, which correspond to the inactivation of the PGA gene or degree of inactivation of PGA gene. One could envision that early frameshift knock out the activity of PGA gene completely, and the cells do not express any GPA-linked molecules on proteins on the surface, versus missense mutations would cause partial inactivation and therefore somehow lesser symptomatology because the cells might be still partially protected, the red cells, due to the residual expression of PGA of GPA-linked proteins. The comprehensive workup should include the dimer, which gives us information about the propensity to form clots. The dimer can be mildly positive. Very high D dimer should trigger further investigations. Iron studies, sometimes the anemia is actually augmented by the iron deficiency, in which case iron supplementation might help the bone marrow to cope with anemia by increased production. So, and once iron is supplemented, then often reticulocytes are highly elevated, but they can be highly elevated at presentation, of course, consistent with the diagnosis of hemolytic anemia. Now, the degree of increase in granulocytes in reticulocytes correlates with the severity of coincidental bone marrow failure. The same is true for platelets. Original diagnosis requires bone marrow. Usually the follow-up in uncomplicated cases or in cases that are classic do not require serial bone marrows or bone marrow evaluation. The diagnosis can be made on peripheral blood. It's good to have the original bone marrow, initial bone marrow, and only in cases of major changes in blood counts or clinical course, the subsequent the subsequent bone marrow biopsy is needed. Yeah, it is important to sort of have in mind the classification of this disease. The standard evaluation would find a small PNH clone in many patients with aplastic anemia in up to 50%. Tiny clones of 1% or lesser do not warrant the diagnosis of PNH, and therefore I tend to think that there is a diagnosis of having a PNH clone without having the PNH disease. So this would be aplastic anemia with coincidental or with tiny PNH clone, versus the increased size of PNH clone in the course of the aplastic anemia warrants the diagnosis of aplastic anemia PNH syndrome. In this syndrome, we have mix of hemolysis, intravascular hemolysis, and bone marrow failure, so platelets are usually decreased, including and reticulocytes might not be adequate to the degree of anemia despite hemolysis. So at this point, the clinical course is very variable, and many of us studied the determinants of other clonal evolution. Is somehow difficult to predict as they progress versus the smaller clones can linger for a long time without expansion. In any event, the end product of this clinical course is usually secondary hemolytic PNH. So the PNH, hemolytic PNH, the disease requires a certain size of PNH clone by granulocytes. The experts argue, where do we do the cutoff? I usually tend to think that the clone greater than 20% warrants the diagnosis of PNH. If there is hemolysis, it would be hemolytic PNH. And by itself, the patients can present with hemolytic PNH at once without history of prior aplastic anemia. I refer to it as a primary hemolytic PNH, whether there is a period of cytopenia and cryptic or subclinical bone marrow failure prior to it, sometimes difficult to establish. Usually, primary hemolytic PNH, despite any interrogation and investigation on patient history, reveals really no clues as to the fact that there was prior aplastic anemia or prior evidence of subclinical immune-mediated bone marrow failure, versus in a secondary hemolytic anemia, which has in a full-blown version identical clinical features. We have a prior history of aplastic anemia. These patients are usually followed, they receive treatment, and it's pretty clear that the PNH is a secondary clonal complication of aplastic anemia. Sometimes it constitutes a therapy to anti-complement therapy, and particularly in cases of type 2 PNH, whereby patients has long periods of seemingly well-being, and therefore and only presented at times with so-called hemolytic crisis. The frequency of this crisis determines the impetus for initiation of therapy. If the hemolytic episodes are very rare and otherwise counts well preserved, there might be some consideration of watching, and some patient elected. Obviously, the drug injections, so this somehow might impact patient lifestyle. However, obviously clear cases such as patients presented with thrombotic complications or patients with severe anemia, there is no dilemma in terms of starting of anti-complement therapy. So these borderline cases, in which case the preponderance of evidence supporting initiation of therapy makes a decision, including how symptomatic is the patient, even if anemia is not severe. Is there trauma? Is there history of thrombotic complication? Is the dimer sky high? At that point, it's worthwhile to mention that the clinical course by itself, also not as a nosologic classification, can be either constant severe crisis. These are usually patients with a significant type 3 clone, versus whether the patient has relatively indolent disease interspersed with hemolytic crisis. Now, in those patients, the attacks of hemolysis are usually more severe because they, in the periods of relative well-being, they accumulate PNH cells, and then it usually the crisis is associated with a significant drop of hemoglobin, sometimes secondary kidney failure, and all the symptoms inherent to it, versus patients who have chronically severe or a high degree of complement activation. These patients destroy red cells on a steady state level, and therefore there is no crisis per se. There are only fluctuation of hemoglobin in the lower range of the spectrum because of the steady high activity of complement. So once it's decided that patients should be treated, the question is, how do we treat them? And up to 2 weeks ago, we had two choices. We had a C3 inhibitor, Empaveli, and C5 inhibitor called Ultimaris. The administration of Ultimaris includes every 2 months infusion after a loading of every 2 weeks times 1, versus Empaveli is administered twice a week via sub-Q injections. And the drugs in upfront setting are equivalent. There are major differences as to ability to control so-called extravascular hemolysis that happens in some patients who are on C5 inhibitors. But it's upfront very difficult to predict whether this particular patients will have extravascular hemolysis, and therefore in the novo setting, the seeming advantage of controlling extravascular hemolysis is not strong. Only maybe 10 to 15% of patients will experience extravascular hemolysis, in which case, one can switch them to a more distal complement inhibitor like Empaveli, and now we have also iptacopan. So currently we have the SERT inhibitor, which is a very distal inhibitor in the alternative complement cascade, targeting factor B. This is very effective drug, again, in an upfront setting, and it would control also the extravascular hemolysis. Thus, in upfront setting, these drugs are mainly equivalent. Obviously, there will be no extravascular hemolysis or significant extravascular hemolysis with Empaveli and with iptacopan, but otherwise, the C5 inhibitors are extremely effective, with only minority patients who don't have sufficient responses. And these patients can be then switched to the distal inhibitor. So it's difficult to make recommendations. It depends on the lifestyle. Older patients don't want to deal with a gadget that are needed for self-injection. Some patient, however, enjoys the freedom of not having to go to the clinic. There is a driving time. There is also a preference of the health system or insurance that they have, which might have on formulary one or the other drugs. the experience with oral drugs is less, particularly in terms of approval, insurance, but many patients in upfront setting confronted with the three options, assuming that we don't have a particular bias, I would guess would select an oral inhibitor. However, I noticed that many patients who are established and have very good responses with C5 inhibitors, they, while they are interested about other drugs, when it comes to it, they don't want to quote unquote rock the boat and the every 2 months infusion where they are tucked in and this is built into their lifestyle and work schedule. This administration can be quite convenient. Okay, so this would be an upfront setting. I wonder whether we can go back to the last question.
Yeah, the last question was, can you talk about the clonal regression?
Yeah. So I noticed that the patient originally presented with low hemoglobin, but when the bone marrow examination was performed, the hemoglobin was normal. Is it correct?
Yeah, 2 years later, yes.
Yeah, this was later. And, this does not necessarily mean that the clone is regressing. As mentioned, the episodic hemoglobin, particularly in a patient with type 2 PNH, might have periods of relative well-being where the hemoglobin is good. And then after, if we would sample CBC following a crisis, it would be significantly lower. However, when serial evaluation over years, let's say in semi-annual PNH flow, might reveal a regression of the clone. This is rather late occurrence among 150 fully hemolytic patients that I have followed. Maybe we experienced this 3 to 4 times in a clear setting. And of course, this is a very happy event for the patients, and to the extent that in 3 occasions we stopped complement inhibitor, and they were free of any intervention. However, so what are the causes of it, and how one can explain? So they are good causes. One would think that if the hemopoiesis is mastered over the years out of original PNH initiating stem cells, the stem cell exhausted itself and dies out while the normal bone marrow had time to, if you wish, repopulate the bone marrow following aplastic anemia and takes over hemopoiesis. I have experienced it less commonly, but particularly in young patients. This is described. I recall 2 young women who eventually lost the clone and were fine. However, in other patients, what happens is they actually have a clonal mosaicism whereby the coexisting myelodysplastic clone characterized by additional myeloid mutations grows and outcompetes PNH. So if you wish, PNH clone is squeezed out. Essentially, such a scenario is compatible with clonal evolution to myelodysplastic syndrome, which, according to current classification, can be originally very mild. So the patient might experience a holiday for a long period of time whereby they don't have any hemolysis. Hemoglobin might not be perfect, but they don't have any more PNH. The MCV is high, and next generation sequencing would reveal a new occurrence or expansion of a prior coexistent myeloid clone characterized what typical myelodysplastic syndrome style mutations. The cases that I have seen show a spliceosomal mutation SF3B1. I saw a patient with sickle. I saw a patient who lost the PNH clone and was replaced with monosomy 7 clone coexists in the same patient. So not all that good news. Obviously, we are looking, and every patient will ask, well, is there a spontaneous remission? And sometimes this would be a good event, but I think we have to be careful to evaluate whether loss of PNH clone is associated with replacement or outcompeting of PNH clone with another aberrant clone, which would highlight early myelodysplastic syndrome, or at least a sickle, as a prodromal or initial stage of myelodysplastic syndrome.
Okay, great. So I think before we will move to the second question, the question I have, so when you describe this evolution of this PNH clone or expansion of this PNH clone and progressing into the syndrome, AA-PNH syndrome, how often do we see this PNH clone expansion, and how often do we need to repeat the flow cytometry to catch this kind of hemolysis progression or disease emerge?
Well, in stable patient, I decide upon repeating the test on anniversary meetings, milestone meetings that you have in regular follow-up. I think monitoring once every 6 months or to once a year is reasonable. However, the PNH flow should be repeated should the balance between bone marrow failure and cytopenia and hemolysis switch. At that point, we would like to establish that the patient PNH clone did or did not increase, or whether he warrants now the diagnosis of hemolytic PNH. Obviously, in aplastic anemia PNH syndrome, platelets should be decreased, and patient reticulocytosis might be not as prominent as hemolytic PNH, whereby the bone marrow failure component is pushed into the background, and the hemolytic picture with reticulocytosis predominates. So, at occasions that warrants this due to change of clinical status, but otherwise, as a part of annual or semi-annual evaluation.
Okay, great. Just to reiterate your point that getting the PGA mutation is not really too sensitive, and so we should not be looking, because most of the myeloid panel that we are using commercially available, they do not include the PGA, and it's not a necessary testing to do it. Rather, we should focus on the flow.
Yeah,
okay,
no,
great.
Definitely. It's not helpful in establishing the diagnosis. However, if it is on the panel, it addresses the issue of initial presentation. I had on multiple occasions patients who were referred with myelodysplastic syndrome, and PNH was PGA mutation was asserted on next generation sequencing panel, in which case it made me wonder. And then when I dug more, I realized that it was not low-risk MDS with erythroid dysplasia, which in my opinion is not sufficient in this setting to establish the diagnosis of MDS. It was all along aplastic anemia that was unrecognized. And, we as doctors, we say, well, so this is PNH that evolved in the context of MDS. Actually, a typical garden variety MDS does not have PNH clone, and the frequency of detection on big screens of detection of PNH clone of patient with typical myelodysplastic syndrome was extremely low, less than 0.5%. And again, the presence of PNH clone, it's always a hint that there is an immune component, and maybe the original disease was actually immune controlled or immune mediated.
Then you have to look for the context of the cellularity and dysplasia kind of percentage, right?
Yeah, I mean, obviously, in myelodysplastic syndrome, you would like to see normal hypercellular bone marrow. But again, it would be not distinctive for PNH clone. I always say to people who start understanding PNH, look at the biopsies that is cellular, and now try to take away all erythroid components, which would be the PNH clone. And when you think about, you see hypocellular bone marrow. If you could wipe out, with a marker, with a eraser, the erythroid components. So in this respect, that's why the diagnosis is sometimes that's why the pathologic diagnosis is sometimes mixed up, because both myelodysplastic syndrome and PNH are cellular bone marrows, and they both have erythroid dysplasia, but usually, at least in this setting, and my presence of myelodysplasia would be required in order to forward the diagnosis of myelodysplastic syndrome, including cytogenetics and other signs. But just to find cellular bone marrow and erythroid dysplasia is not sufficient to make a diagnosis of myelodysplastic syndrome, particularly in the setting of reticulocytosis, would be very atypical for MDS, where we would rather expect reticulocytopenic anemia.
Okay, got it. Okay, so we'll move to the next case. This is a very interesting case that to go over. This is a 53-year-old Caucasian male presented with several months of fatigue, aphasia, sudden onset aphasia, and petechia. His hemoglobin was 3 with ANC of 200, platelet was single digit, LDH was 1500, haptoglobin was low, the indirect bilirubin was 7 milligram with a high D dimer. And so he lingered around and he was worked up, but at the same time, his MRI showed that he had a subacute infarct with a petechial hemorrhage a couple weeks after his initial presentation to the hospital. So his initial biopsy, bone marrow biopsy, showed 60% cellularity with a marked increase in erythroid and megakaryocytic predominance. There was a mild dyspoesis, and there was no cytogenetics or MDS fish abnormalities. And NGS was unremarkable. Eventually, after a 2.5 and 3 months kind of hospital stay, they did a PNH clone, and then they found this 85% or 93% granulocyte clone with an 11% red cell clone, and the classical PNH diagnosis was made with the assumption of normal cellular bone marrow. But again, remember, this patient had the platelet count of 9 and had very low ANC. So it was not really compatible to say this is a classical PNH. When we saw him, we repeated his bone marrow. There was a decreased megakaryocyte and granulocyte, and there was very much increased erythroid precursors. And so the overall cellularity was 10 to 20%. And that was unremarkable with the cytogenetics and MDS fish panel. And the neutrophil clone size was 95% with the 10% red blood cell clone. So basically, he was frankly aplastic PNH syndrome, and he was kind of experienced worst outcome of PNH in initial presentation. So the question to Dr. Maciejewski is that, how often do we see this classical PNH with severe aplastic anemia, namely the AA-PNH syndrome? And how do you manage this severe aplastic and concurrent classical PNH patients? And the third question is, in case of this syndrome, how significant the reliance of the overall cellularity? Because as we saw in this case, initially he was misdiagnosed with classical PNH. Does it matter? It doesn't matter really. Maybe he could be mistreated as MDS because of that dyspoesis, right? The fourth question is, when we are approaching to these people, do you treat both, or do you rather to target like both of them with a transplant? And what is your approach for proximal complement inhibition versus distal, especially for this syndrome patient and the risk of breakthrough hemolysis for each agent? And any concern for PTH for when you are using the proximal inhibitors? And where do you see the near future going with the PNH treatment that we have over a 10 investigational medication that is being worked up for PNH patients?
Yeah, thank you. All valid questions. They are a typical presentation of PNH. The usual scenario is post-aplastic anemia hemolytic PNH, but in rare instances, PNH clone is established, but the hemopoietic suppression of the bone marrow is so strong that even PNH clone is suppressed. Now, in this particular patient, it seems that this was the case, but if we look at overall counts, we see that both the clone itself as well as normal hemopoiesis is wildly depressed, and even if we would assess the whole clonal burden on absolute levels, it would be significantly lower because they are not diluted by normal cells. So all the patient has is functioning PNH clone, but it seems that in this patient, the immune escape is not absolute. This is how I interpret it. It's somehow more difficult scenario to treat, but at the end of the day, a similar treatment has to be applied depending on the staging of aplastic anemia, age of the patient. Obviously, younger patients should undergo bone marrow transplantation versus older patients, or when they are comorbidity and other precluding circumstances would receive ATG. The cutoff value, there is of course the preference of the patient. The cutoff value in terms of age is set very low by pediatricians, but I like to think that 30 would be a good number, 30 years old, in which case a patient would be treated with ATG. In the beginning, I was very hesitant when the complement inhibitors were introduced, because I was worrying that ATG would not work because would be somehow the complement mediated lysis would not be full, and that would decrease the efficacy of ATG. But one has to remember that PNH, the complement activation is via alternative pathway, not a classical pathway, and the complement inhibitor have very little impact on classical pathway, and thus ATG does work even in patients who are on C5 inhibitors. This is experience. Of course, if disease is not severe, one could think of having a period of time with careful monitoring of cyclosporin or Prograft and erythropoietin and EPAC. The trials are ongoing, testing ATG, cyclosporin, EPAC versus cyclosporin, EPAC combination. The word is not out. I think it's not going to be that clear. By itself, ATG versus plus cyclosporin versus cyclosporin, ATG was clearly superior in inducing remissions. Now, the question was whether this patient in this scenario does need complement. He's not making very many red cells. And if the reticulocyte count is extremely low, then the hemolysis that patient experience would be not that significant because there is a total suppression. Now, one could think that once immunosuppressive therapy is initiated, this would change, and then once reticulocytosis is observed, this would be the times that the patient would benefit more from the blockade. For now, the hemoglobin will be diluted by transfusions, and which would further decrease the hemolytic component of the anemia. So, but in overall, if one would have a sort of pantheistic approach to pancytopenia in this patient, at certain point, the complement inhibitor might be useful in addition to immunosuppression. Yeah, other cases, and are patients who have who have a hemolytic PNH. These are usually, in my opinion, patients with type 2 PNH. And again, it's a sort of waiting game when some trigger in the life of patient, such as infection or some other episode, would trigger major hemolysis. Usually, these patients have very small gradient between PNH red cells and PNH granulocytes, which indicates that the degree of hemolysis is very little, or the patient catches up with the hemolysis. I mentioned already the distinction of clinical course of patients who have crisis versus patients who have constantly high complement activity. And of course, we believe that the risk of thrombotic complication is significant in patients with PNH, and some even present with very mild anemia and this, such as what Chiari syndrome and others at presentation, versus patients who have for years PNH and never have thrombotic complication. Overall conversion rate is probably 30% over the time or the risk over the years. 30% of patients with PNH will experience thrombotic complications. Not actually, 20% will never have thrombotic complications. I think the dimer is useful to sort of assess in which patient in which direction patient tend to go. High D-dimer is not surprising in patients with PNH, but very high dimer, to me, I think, is definitely an argument for initiation of anti-complement therapy if there were no other factors that would decide versus the patient who have normal D-dimer. The sort of thrombotic argument might be less strong in the decision-making process. I recall that there was, I think, one of the subsequent questions pertained the management, right? So we discussed already concomitant immunosuppression and the fact that this can be admitted even including ATG. Again, patients who have low platelet count respond to cyclosporine alone very good. Reticulocyte count through immunosuppressive therapy will increase, so somehow the compensatory chemopoiesis would be more efficient, which, if implemented, might make the argument for anti-complement therapy more compelling. If a patient has fully compensated hemolysis, one could think that maybe anti-complement therapy can be delayed, and it depends, of course, on the constitution and mental preferences of the patient itself. Themselves, they are those who worry very much and want to do everything, and they are patients who rather don't take drugs or rather wait, are procrastinators.
The subsequent question was, how do you approach this PTH cases like breakthrough hemolysis? You mentioned about the extravascular.
Yeah, I think, I mean, first of all, I tend to think that patients who are underdosed cannot be reversed as to having BTH. So those BTH should be defined in patients who otherwise have very good hemoglobins and are very well controlled in terms of hemolysis, low LDH. If a patient has constantly elevated LDH, they could be some superimposed BTH, but it's difficult to make this diagnosis. So the first would be, is it really BTH, or is this chronically underdosed complement inhibition? The second issue is in BTH, they are always triggers, so the triggers should be treated, and these triggers are usually acute and not chronic. As BTH would be episodic, and then the severity of BTH is, of course, predicted to be much stronger in patients who have very good responses because they accumulate due to protection of red cells, the red cell pool that is susceptible to hemolytic crisis. And it has to be mentioned that really even not complete inhibition can be very dangerous and trigger BTH. Now, on clinical grounds, if you look at clinical trials, the rate of BTH has not been that high, and even while there was theoretical, fears that because of very good responses, lack of reticulocytosis, even in some patients, and very high red cell clones, if BTH occurs, is going to be catastrophic. This really has not translated in the clinical trials that were published into really the high rate of complications. So I think it's an important consideration, but to me, the impact so far has been not that significant. We all know that if BTH happens, we have always a backup of transfusion. Usually the Medrol pack helps. Patients should be alerted to a sort of treated early. And only the relentlessly severe BTH could constitute the problem. Patients who self-administer the drug, like on Empaveli, could be advised to inject Empaveli more frequently on daily basis. Patients who take oral drug could be advised to take an extra dose, and only in rare circumstances over the last 10 years I had to infuse eculizumab on emergent basis.
Okay. Got it.
So a problem, but not, I think, in a clinical praxis, it has not been a major issue to me. I'm aware of it. I know what to do, but it's not like it's going to be very, in most instances, the BTH would be self-limiting and would constitute increase of LDH for a couple of days, or maybe drop of hemoglobin by a gram.
Okay, got it. So you're saying when you start any C5 or C3 or proximal or factor B or D's, factor B's, then the factor D inhibitors, the approved one, then you have to argue, factor B inhibitor that is approved. So you can say, you're saying when you are putting these people on this medication, you have to watch if they have any extravascular hemolysis, right? Or if they will have any complement activation event that will lead to a breakthrough hemolysis, then you may need to intervene because of the severity of the hemolysis, correct?
Well, in those who receive C5 therapy, these are the ones who might have extravascular hemolysis. The extravascular hemolysis in patients on distal inhibitors such as Empaveli, so C3 inhibitor and factor B inhibitor, and theoretically factor D and others, or in more distal setting, this is extravascular hemolysis should not be a factor. And if it is, then this is usually due to underdosing. In the setting, extravascular hemolysis usually does not occur unless patient is on C5 inhibitors.
Okay.
It is inhibition of C5 that sets up the stage for red cells to accumulate, which are coated with C3b and A. And only in this setting, the extravascular hemolysis, which is usually by far less brisk than intravascular hemolysis, can happen. Under normal circumstances, when there is no C5 inhibition, the membrane attack complex, the final step of the complement cascade, is so effective that there is no time, if you wish, for extravascular hemolysis because the red cells are blown to pieces. And this is only when C5 is inhibited that there is enough time, if you wish, for extravascular hemolysis. But it should be clearly distinguished from BTH. These are not two different. This would be a chronic, if you wish, BTH is really underdosing. And extravascular hemolysis cannot be mitigated with increase of the dose of C5 inhibitor. And there are ways to distinguish these two.
Okay. The ways are the DAT positivity sometimes and having a super high, very low LDH, not to the level that you will see with the BTH, because BTH is intravascular event. Anyway, we have some trainees in the session, that's why. So,
Yes.
Dr. We have a couple more minutes left. I think we are done almost with the presentation. Does anyone has any question? Please feel free. We have a couple more minutes. We should take this opportunity to ask Dr. M and learn some.
Hello, Dr. M. This is Matt Hancock at UT Southwestern. I have a question about starting and stopping anti-complement therapy. So do you start complement inhibition in the setting of acute severe hemolysis and thrombosis for classical PNH? Do you start that urgently in the hospital, or can you kind of wait a week or two to start that outpatient for a patient with a large PNH clone and sort of life-threatening thrombosis?
Sure. I think for thrombotic complications, there is more urgency than actual hemolysis, which can be very well mitigated by transfusions. So I have to say that it has been a long time that I had this catastrophic case where it crossed my mind that we have to drop everything and try to get the drug approved. In most centers, the only Soliris is on the formulary on emergent basis is available, particularly because of atypical HUS. So a classical setting where you might think it would be postoperatively when there is otherwise a lot of things going on and one really want to take this out of equation. Otherwise, there are many preclusions to initiate a complement therapy instantly, including the approval process, including the fact that in most of the circumstances, it would not be a life-saving, and we go the orderly process of vaccination and so on. However, antibiotics can be given to prevent meningitis, and it is not impossible, if available, to administer Soliris on emergent basis.
Great. And I guess, can you walk us through how you would stop anti-complement treatment in a patient with PNH, classical PNH, and what sort of antibiotic prophylaxis do you use, or if you use antibiotic prophylaxis?
Yeah, I mean, you know, the practical part is that these patients whom you start usually have the disease for a long time. So it's very difficult to make an emergency out of starting the drug when patient has likely, based on clinical chart, already several years history of PNH, right? So by this virtue, one would go through the old regular process of administering vaccination, getting approval from insurance, and administration. Yeah, clearly this process can be expedited, but you know sometimes there is no really reason to expedite it. If expedited, the drug can be lack of vaccination is not a preclusion because patient can be prophylactically treated with antibiotics and vaccinated subsequently. In fact, in some places, this is recommended experience widely, but some centers reported that in highly hemolytic patients, vaccination triggered, if you wish, additional hemolysis and worsen the clinical picture, and therefore they prefer to give antibiotics, give complement inhibitor, and then vaccinate. But this has not been our standard of care.
Great, thank you. Okay.
In other words, there is no excuse if really it's considered life-saving, like I would say massive Budd-Chiari syndrome or some other, intracranial process, to give Soliris to a PNH patient because he was not vaccinated. Such cases. I mean, this should not be an issue.
Okay, great. Thank you, Dr. Maciejewski. It's been an honor to host you, and we will look forward to host you in another session. Thank you all for joining us.
Thank you very much, and I'm looking forward to the other presentations.
Thank you.